My weakness.
Well, you do MRI physics. That's my weakness. I'm like, I don't know what you're talking about, like lining up the protons or whatever it is you guys do in MRI. All right, respiratory. We'll go through this pretty quickly. So VQ imaging. Um, uh, so we're looking at perfusion first. So TECMA is going to be for our perfusion, and these are actual particles. We want them to be between 10 and 90 microns. A micron is also known as a micrometer. We want 90%, so most of them, none greater than 150. And this is actually what a hemocytometer looks like with the particles that are on that grid. And so it's a qualitative assessment. We're just looking at the particles to see if they're about the right size. The ventilation portion, we have a lot of different options. We can do TEC-DTPA. We can do Technogas. I don't think Technogas is going to be on your exam yet because it's just been approved. And we can do Xenon. Krypton is no longer on the exam. So the different studies that we can do perfusion, ventilation, and quantitative. So perfusion and ventilation are usually done together. Quantitative is going to be done pre-op if a patient's going to have surgery for lung cancer. We're going to do that to see if we can remove part of the lung and if they have enough function to sustain life. All right, so why do we do these? One reason, pulmonary embolism, okay? It can be acute or it can be chronic. We can't tell the difference. We can just tell if they have one. So we can only tell if it's acute or chronic based on their history. And we can quantitate. And then also I threw right to left cardiac shunts in here because we use TEC-MAA for it. And so we'll talk about that at the end. So what is a PE? A PE is basically a DVT that broke off. So DVT is a deep vein thrombosis. You got this blood clot that forms, part of it breaks off, and once it breaks off and goes in motion, that's a pulmonary embolus. Because in a vein, all venous activity goes to the right side of the heart, and then it goes to the lungs. That's why it lodges in the lungs. Okay, so if you have a blockage that forms in an artery, then that can go to the brain, and that's going to cause a stroke. But if you have a blockage that forms in a vein, it's going to go to the lungs as a pulmonary embolus. So what causes it? Well, you have something in your body called fibrinogen. Fibrinogen is made in the liver. You have it normally. You need it in order for your blood to clot and for you not to hemorrhage. It converts into fibrin. Okay, so fibrin is something that makes up the clot. When the blood clot breaks down, and it breaks down by a process called fibrinolysis. So your body's doing this normally all the time. It's making clots and it's breaking them down, and it's normal. When it breaks them down, we have something called fibrin degradation products. So that's what's left over when your body breaks down a blood clot. And there's a test for fibrin degradation products. Do you know what that test is called? That's the D-dimer test, the D-dimer. So a D-dimer test is very sensitive for finding these fibrin degradation products. But the thing is our bodies are normally doing this all the time. So if you have a positive D-dimer, you might have a blood clot, but you might not. If you have a negative D-dimer, you do not have a blood clot. So we do a D-dimer test before we do a PE scan or a VQ scan to rule out those who do not have it. All right, treatment is going to be anticoagulants, but we don't give anticoagulants to break down the clot. We give anticoagulants to prevent new ones and to prevent expansion of existing ones. Our body breaks down the clot itself through fibrinolysis. All right, these are all the risk factors. That's a lot, but it can be broken into 3 categories: sedentary, smoking, and hormones. So you see a couple areas: estrogens, postpartum, pregnancy, that's all hormones, okay? Birth control pills. And then these others, surgery, burns, anesthesia, congestive heart failure, immobility, obesity, advanced age, cancer, a lot of those are sedentary. And then smoking is the other one. All right, symptoms. All of these are symptoms, including death. Many times these aren't diagnosed until death, because if it's an acute and it's a big PE, it can cause almost instant death. It's a very acute kind of thing. All right, so the basics, we're going to look at the airflow and we're going to look at the blood flow. And since it's a blood clot, we're going to see a defect in the blood flow, no defect in the airflow. Okay, let's do some labeling. What's this one?
It's a AP.
It's anterior.
Anterior.
You're definitely multimodality. All right, what's this one?
Posterior.
Posterior, very good. Okay, how about this one?
It's the right side, RAO.
RAO, yes. Okay, how about this one?
It's the LPO. Yeah.
LPO, very good. How about this one and this one? Let's do this one first.
This is the right lateral.
Yes. And then this one?
It's the left lateral.
Okay, and then this one?
That will be the LAO, the right, right RPO.
RPO, and then the last one?
The LPO.
LAO, because there's that. Yep, excellent. You're the first person I've worked with that got all those right. All right, so these are perfusion defects. This is what we're looking for. This is actually a normal lung scan. This is vent, perfusion. And the reason I can automatically tell this is ventilation is because it's not homogeneous, and I can see the esophagus and stomach. So this is normal, and the reason I know it's normal is because the perfusion is normal. If the perfusion's normal, you don't even have to look at the ventilation. Okay, so this is what we're looking for. This is a perfusion defect. It's wedge-shaped and normal ventilation. So that's a mismatch, positive for PE. This one is a matching defect, so that's negative for PE. This one is a reverse mismatch. Sometimes you can get that with severe pneumonia. Okay, so a lot of different things that we can do for PE. If our patient has emphysema, should we do a CT or a VQ?
CT.
CT, yes, because it's anatomical and physiology is going to affect our images. They're going to look awful. Okay, let's skip that. You know all this stuff. All right, so where do the particles actually lodge? All the way down in these capillaries and arterioles. So this is the size, 35 microns for the terminal arterioles. The capillaries are down to 7 to 10 microns, which is why we want 10 to 90 microns for the particles. And there's that hemocytometer again. Each box is 50 by 50 microns. Okay, recent radiograph within 24 hours just to rule out any other causes of the patient's symptoms. A lot of different tests we can do. CT is most common. Also that D-dimer that rules out people that don't have blood clots. ECG, blood gas, pregnancy. If somebody's pregnant, do they get a VQ or a CT?
VQ.
How come?
So we don't have a lot of the breast radiation to the breast.
Yes. Wow, you got all of this. You're smart. All right. So we pretty much do CT on everyone. All right. The algorithm now is if we think they have a blood clot, a PE, we're doing a CT unless we can't. And these are the reasons we can't. If they don't have good venous access, because we have to bolus the contrast. If they have a sensitivity to the contrast, if their renal labs are not normal, and also if for some reason we can't give them that higher radiation dose, which is pregnancy. Okay. So the normal images, abnormal, labeling. It sounds like you have that down. Okay. So the mechanism of localization is capillary blockage. And if the patient has a right to left cardiac shunt, so we're going to talk about that a little bit later, you're going to do a whole body image and you're going to see brain and kidneys. Normally you shouldn't see brain and kidneys at all because it's all going to lodge in the lungs. The only way for it to get out is to go to the left side of the heart through a shunt. All right, so what happens to these particles after we give them to the patient? Patient actually does what it's supposed to do, breaks it down through fibrinolysis. And then once it breaks it down and the particles are even smaller, then the liver spleen comes in and takes up those particles because that's what it does. Okay, I've got a lot of stuff. All right, so how do we inject these patients, upright or supine?
Supine.
Very good. How come?
Because you want the particle to go into the capillary cap,
Capillaries?
capillary.
Yeah. So if I'm sitting upright, I have more blood flow to the base of my lungs. If I'm laying flat, now I get more homogeneous distribution. So I don't have more activity at the base. All right. Straight stick or butterfly?
Str- Butterfly.
Butterfly. Yes. Yes. Definitely either a butterfly or an IV, because if you inject MAA straight stick, and most people aren't doing straight sticks anymore, but some people are. If you inject straight stick, if some of that blood gets into mixes with the MAA, it can cause the particles to clump together. And if that happens, then you have hot spots in your perfusion image. So it's really bad. We're supposed to inject slowly. Most people don't know this. And instruct the patient to deep breathe while you are injecting. Take deep breaths. So this is what the butterfly system looks like. Stopcock, you're probably familiar with those. Supine, this is why. Low energy, high resolution collimator, 500,000 counts per image. These are all the images you can take. All right, now let's talk about ventilation. So there's three different choices we have. We have aerosol, gas, and then Technogas is actually a micro aerosol. Are you guys using Technogas there yet?
No, when using DTPA.
DTPA, okay. All right, so which one is going to have the highest radiation burden to the patient? I'm not going to look at krypton. So xenon versus Tech DTPA. We're only giving 1 millicurie of Tech DTPA. We're giving 10 to 20 millicuries of xenon. The physical half-life of Tech DTPA is 6 hours. Physical half-life of xenon is 5.3 days. But the biological half-life is a lot different. So that means that the dose of xenon is a lot doser than the dose of Tech DTPA. So for a pregnant patient, Tech DTPA or xenon would actually be better because it's less dose. All right, so these are the two commercial systems for xenon. And the way that this works is we're going to do 3 phases. We're going to do the single breath phase, where we inject the xenon into the breathing apparatus and we have the patient hold their breath. The length of time for this image is as long as the patient can hold their breath. Once they start breathing, we go to equilibrium. Both of these, the system is closed, which means that what we're going to do is there's actually a balloon inside of here, and we fill the balloon up with oxygen. And then we add the xenon. And so the closed system, the patient's only breathing in and out that balloon, which is oxygen and xenon. Once we have our equilibrium, then we're going to start the washout phase. And the system goes to an open system, which means the patient's going to breathe in room air. And when they exhale, we're going to capture all of their exhalation into a trap. And the trap, what's the trap made of? Do you remember?
Does xenon.
Charcoal trap. Charcoal trap. So the charcoal and the xenon form a chemical bond. So as the patient is exhaling through the charcoal traps the xenon, and so it doesn't go into the atmosphere. Okay, this is what I just said. This is the initial breath. This is the equilibrium. How do I know this? Because there's not as many counts here. All right, so both of these are in the closed system, but this one, I'm just collecting as many counts as I can while the patient's holding their breath. This image is going to be for 1 to 3 minutes. Okay, so we talked about that. All right, so here we go. Single breath. For some reason, they took 2 equilibrium images. I don't know why. And then the washout. And then sometimes during the washout, you can get some posterior obliques. Really not necessary. But by the time you get here and you're looking at your count rate, there's no counts left. So it's very quick that the counts actually leave the patient. All right, so we know what the charcoal filter does. That traps the xenon. What does the soda lime do? That is going to absorb carbon dioxide, because when the patient is breathing in and out of that balloon, they're exhaling carbon dioxide. So we need something to absorb the carbon dioxide so the patient doesn't rebreathe that in. All right, what does the dryer right or the silica gel do? That one traps moisture because there's moisture in our breathing and we want to keep the system clean. And so we're going to absorb the moisture to prevent that from happening. Now, the Dryerite is blue. And when it absorbs moisture, it turns pink. Okay. So we're going to use a filter, face mask, put it all together. This little port right here is where we'll inject the xenon. This is a xenon gun that connects to that little port in the mask. And then the vial goes inside of here. We push on the back and there's a prong here and the prong will hit the rubber stopper, allowing the gas to come out. And then you can squeeze the bulb a couple times, which causes the gas to go into the mask. This system here allows you to put the xenon directly into the system instead of using a xenon gun. You're going to do the same thing. You're going to push down on the xenon, and then you're going to pump the bulb a couple times to get the xenon into the mask. And then it directly goes into the mask. That's the charcoal trap. This is the back of the system. So you have, that's the Dryerite. See, it's blue. That's trap the moisture. This is the soda lime that's going to trap the carbon dioxide. All right, when you first start, this is where you're going to fill up the balloon. You change it here. That's the first two phases. So the system is closed. The patient's breathing in and out of the balloon. Then you switch it to washout, and that's where the system becomes open. Inhale room air, exhale through the charcoal trap. All right, this is what you do. So you probably don't need me to tell you about this. 3 to 5 milliliters of Tec DTPA, 40 millicuries. But of that 40 millicuries, only 1 to 2 millicuries gets into the patient. Aerosolized through a nebulizer. Droplets are really small. Do you have this system?
No, we have, it's like a mouthpiece with the two taps. The patient put the tube in and then down, and then it connect to like a balloon, and then we inject it onto a little silicone thing.
Okay. There's a lot of different systems out there. So this one is basically just like a lead lining. And then on the inside, you put this system, which has the tubing and it has the filter. And then you can inject directly into a port, and it can go on an IV pole and the patient breathes it in. Oxygen should be turned all the way up, 8 to 10 liters per minute. And it takes about every minute, only about 1.1 millicuries gets into the lungs. So you have to vent these patients for a really long time. And that's why Technogas is going to be great, because when you have Technogas, they only have to take like 2 or 3 breaths, and that's it. And it's also a dry aerosol instead of a wet aerosol. So that means that, and it's also not positive pressure. So if the patient takes that out of their mouth, then you're going to be spraying DTPA all over the place. Well, Technogas, the only way to get it in their lungs is they actually have to like suck it in, because it doesn't come out otherwise. So it's a much cleaner process. All right, this is what it looks like. Of course, you're going to see esophagus activity. You also see stomach activity from the patient swallowing. This is what the Technogas generator looks like. I'm not going to go through that because I just don't think that it's going to be on your exam yet. If it is on your exam, those are pre-questions, pre-test questions. It's not going to be counted for you if you get it right or wrong. They're just looking to see if you know this information, to see if it's a valid question for future exams. Okay, and this is why we like it. Here's aerosol, and here's Technogas.
Same patient.
Yes. Yeah. Aerosol, Technogas. Okay. So which do you do first, the ventilation or the perfusion?
Ventilation.
How come?
Because it's low dose.
Yeah, that's very good. All right. What if we were doing xenon for the ventilation? What would we do first?
We do gas first, because the washout is quicker.
Okay. And also because it's lower energy. Lower energy. All right. The well score, this is a pretest likelihood score. This is one of those tests where the physicians want to go in with bias. They want to go in and they want to say, I think this patient has a blood clot, or they want to go and say, I think this patient doesn't have one. And they do that by getting a pretest likelihood. So it's a scoring system based on the patient's clinical picture. If the well score is 4 or less, do a dimer first. If it's greater than 4, go straight to VQ or CT. PIOPED, that stands for Prospective Investigation of Pulmonary Embolism Diagnosis. This is probabilities. This is a probability that the patient does or doesn't have a blood clot. And then you can combine Wells and PIOPED. That's going to make it more confident in the diagnosis. And I don't think the specifics are going to be on your exam, but if you just know what Wells and PIOPED is, you're good. Okay. Matching defect is in both perfusion and ventilation. Mismatch is just perfusion abnormality. Fissure sign here, this is actually low probability for PE. This is just a line corresponding with interlobar fissures. And then the stripe sign is where you see some activity below a defect. That's also low probability. All right, quantitative lung. Can we remove a section of the patient's lung? They have lung cancer. Will they have enough function to sustain life? So we're just going to draw regions of interest, and then we're going to calculate the percentage of function that they're going to lose if they have surgery. And then we compare that function with their pulmonary function test to determine if they have enough function to sustain life. All right. Last thing I'm going to talk about is, I think, right to left cardiac shunt. So if the patient is leaking blood from the right side to the left side and I inject TEC-MAA, then some of that TEC-MAA is going to go to the rest of the body, and I'm going to see brain and kidneys. I can do a whole body scan. And if I want to know what percentage is being shunted, I want to know what percentage is not in the lungs. So I'm going to take whole body minus lungs over whole body. And that's going to give me the percentage that's not in the lungs. All right, we're not going to go through that. All right, the rest of these are calculations, particle calculations. If you want some calculations, I can send them to you, but if you feel confident with them, then don't worry about it. I said that was the last thing, but this is the last thing. Levine shunt. So what this is this is a shunt that's placed in the patient's abdomen if they have cancer that's causing fluid buildup. And this shunt takes the fluid out of the abdomen and puts it back into circulation. So what we have to do is we have to make the fluid radioactive and see where it goes. And we can use two things. We can use MAA or sulfur colloid. And the reason we want to use those two is because when it is picked up in circulation, we're either going to see lungs or liver. So this is what we're looking for. Here's the ascites where we injected, and we inject MAA. So we see lung activity, so we know the shunt is working. All right. The rest of these are TheraSpheres, and I've already gone through them, and that takes us to the top of the hour. Barely got through that one. All right. You have questions?
No, I don't have questions.
All right.